Immunology Insights, Basics and Beyond, Chapter 63, Immunotherapy for Infectious Diseases. Marcello here. Welcome back to Immunology Insights, Basics and Beyond. In our last chapter, we explored how targeted immunotherapies can calm an overactive immune system in autoimmune diseases, dialing down misdirected attacks on self while trying to preserve host defense. Today, we stay with the same theme of immune modulation, but change the enemy once again. This time, we look at pathogens, viruses, bacteria, and other infectious agents. Instead of simply using antibiotics or antivirals, we will explore how we can boost or reshape the immune response itself to better fight infections or, in some cases, to limit immune-mediated damage. So let's talk science. What do we mean by immunotherapy in infectious diseases? Well, when we talk about immunotherapy for infections, we don't mean classic drugs like antibiotics or standard antivirals. Instead, we mean interventions that first provide ready-made immune components, for example, monoclonal antibodies that neutralize a virus. Second, boost or redirect host immunity, such as cytokines or adoptive T-cell therapies. Or third, modulate harmful inflammation, for instance by blocking cytokines that drive life-threatening immune overreactions in severe infections. This is attractive because many pathogens such as HIV, hepatitis B virus and tuberculosis can invade or exhaust the immune response. Drug resistance is rising, especially in bacteria, and some viruses and some infections cause severe diseases not just through the pathogen itself, but through dysregulated immunity, as we see in severe influenza or COVID-19. Immunotherapy tries to tilt the balance, give the immune system what it's missing, or take away what it's doing in excess. Let's start with passive antibody therapies, so borrowed immunity. The oldest form of immunotherapy for infections is passive antibody transfer, giving patients antibodies made by someone else. Historically, this was done as convalescent plasma from recovered patients. Today, we mostly rely on monoclonal antibodies, or MABs, highly purified, well-defined molecules. These antibodies bind the pathogen or a toxin and neutralize it directly. Their Fc region can also recruit immune cells and complement, helping clear the pathogen of infected cells. Here are a few concrete examples. First, respiratory syncytial virus or RSV, palivizumab and newer long-acting antibodies such as nirsevimab are used in high-risk infants to prevent severe disease by binding the RSV-F protein and blocking viral entry into the cells. Second, the Ebola virus. Antibody cocktails targeting the viral glycoprotein have improved survival when given early, neutralizing the virus and aiding clearance before overwhelming organ damage occurs. And third, SARS-CoV-2 in COVID-19. Early in the pandemic, several neutralizing antibody cocktails were used to prevent hospitalization in high-risk patients. As SARS-CoV-2 mutated, many of these lost efficacy, highlighting a key limitation of pathogen-specific monoclonal antibodies, the viral escape. Advantages include a rapid onset of protection without waiting for the patient's own immune response, and particular usefulness in immunocompromised patients who cannot mount strong responses to vaccines themselves, and high manufacturing costs that limit global access. Next are therapeutic vaccines and virus-specific T-cells. We normally think of vaccines as preventive tools, but for some infections there is intense interest in therapeutic vaccination, boosting immunity in people who are already infected. The goal is to amplify virus-specific T-cells and antibodies to push chronic infections such as hepatitis B or latent tuberculosis toward better control, ideally approaching a functional cure rather than mere suppression. Most therapeutic vaccines are still in clinical trials. They often combine, first, novel adjuvants that create strong T-cell responses. Second, targeted antigens such as HBV core or polymerase, designed to focus immunity on conserved viral regions. And third, combinations with antivirals or checkpoint modulators. So far, results are mixed. Immune markers improve, but true cure remains rare. Still, the concept is clear. train the immune system better rather than only suppressing viral replication. A more direct approach is adoptive transfer of virus-specific T cells. This is most advanced in transplant medicine, where highly immunosuppressed patients are prone to reactivation of viruses like cytomegalovirus or CMV, Epstein-Barr virus or EBV, or the BK polyomavirus. Donor or third-party T cells specific for these viruses are expanded ex vivo and infused into the patient. These T cells recognize viral peptides or infected cells via their T cell receptors, kill the infected cells, and restore viral control when the patient's own T cells are lacking. This remains a niche but a growing area, showing that cellular immunotherapy originally developed for cancer can also rescue patients from life-threatening infections. Then we have the cytokine and immune modulating therapies. Sometimes the problem in infections is not too little immunity but too much, or the wrong kind at the wrong time. To boost antiviral states, type 1 interferons, especially interferon alpha, were classic immunotherapies for chronic viral infections. They were widely used for chronic hepatitis B and C before modern direct-acting antivirals and are still used in selected HBV cases. Interferons induce an antiviral state in many cells, increasing expression of restriction factors and enhancing antigen presentation. They can help to clear virus in a subset of patients but cause significant side effects, flu-like symptoms, mood changes, cytopenias. So their role has become more limited. Other cytokines, such as IL-2, IL-7 or IL-15, are being explored in small studies to boost T-cell and NK cell responses in chronic viral infections or in settings of profound lymphopenia. On the other side, in severe infections, especially sepsis or critical viral pneumonia, the immune response itself can cause massive tissue damage. Here we have two important examples. First, in severe COVID-19, dexamethasone, a corticosteroid, became standard of care for patients needing oxygen because it dampens excessive inflammation, and IL-6 receptor blockers like tocilizumab were used in selected severe cases to reduce cytokine-driven lung injury. Second, in bacterial sepsis, numerous attempts to modulate cytokines such as TNF and IL-1 have been made. Most large trials failed, in part because timing and patient selections are critical. More recently, there is interest in treating late immune paralysis in sepsis with agents like IL-7 or GM-CSF to restore T-cell function, but it remains experimental. The key point is that in infectious diseases, immunotherapy cuts both ways. Sometimes we want to boost immunity, sometimes to restrain it, and sometimes both at different stages of the same illness. Last but not least, let's look at checkpoint pathways and chronic infection. In chronic infections such as HIV, hepatitis B, or some forms of tuberculosis, T cells often show features of exhaustion. They express high levels of inhibitory receptors such as PD-1, LAG-3, and TIM-3, and display reduced cytokine production and proliferative capacity. This looks very similar to T cell exhaustion in cancer. Experimentally, blocking PD-1, PD-L1 or other checkpoints can temporarily boost virus-specific T-cell functions, increasing cytokine production and cytotoxicity. However, there are important concerns. First, the risk of excessive inflammation and tissue damage in organs already harboring chronic infection, for example, the liver in HBV. And second, the possibility of immune reconstitution inflammatory syndromes, an excessive inflammatory response that occurs when a recovering immune system reacts strongly to existing infections. As of now, checkpoint inhibitors for chronic infection remain mainly in the research arena, promising as a proof of concept, but not yet standard therapy. So what about the clinical relevance, where immunotherapy for infections shines? Immunotherapy is not replacing antibiotics or antivirals, but it is carving out important niches. It plays a growing role in, first, prevention and early treatment of severe viral diseases in high-risk patients, for example RSV, Ebola, and some COVID-19 settings, through monoclonal antibodies. Second, it is a supportive immune control in highly immunocompromised hosts, for example post-transplant CMV or EBV or opportunistic viral infections, via adoptive T-cell transfer. And third, modulation of immune damage in severe infection and sepsis, as illustrated by steroid and IL-6 blockade in advanced COVID-19. Challenges of course remain. Biologics and cell therapies are costly and complex to produce and administer. Pathogen evolution, especially for rapidly mutating viruses, can undermine narrowly targeted agents. Therapeutic windows are narrow. Intervening too early or too late can both be problematic. And there is always a delicate balance between antipathogen efficacy and the risk of amplifying harmful immunopathology. Nonetheless, these approaches have already saved lives in situations where conventional tools alone were not enough. So what are future directions toward broader, smarter immune tools? Looking ahead, several lines of development are particularly exciting. First, broadly neutralizing antibodies. For viruses like HIV and influenza, these antibodies that recognize conserved regions across many strains are being developed. Combined or sequential antibody therapies might suppress virus long-term, perhaps even enabling drug-free remission in some HIV patients. Second, vector or mRNA-encoded antibodies and T-cell receptors. Instead of infusing protein antibodies, genes encoding these antibodies could be delivered by viral vectors or mRNA, allowing patients to produce the antibodies themselves for a defined period. This could democratize complex immunotherapies and simplify dosing. Third, integrated regimens. Rational combinations of antivirals, immunotherapy and vaccines tailored to the stage of infection, so for example acute versus chronic, and the patient's immune status, for example immunocompetent versus immunocompromised. For example, cure strategies for HPV are being explored that combine antivirals, therapeutic vaccination, and transient immune checkpoint modulation. And fourth, better biomarkers. Immune profiling to distinguish when a patient needs more immune activation, for example to control viral chronic infection, versus when they need more immune restraint, such as in an impending cytokine storm. The underlying theme is that immunotherapy for infectious diseases will likely become more personalized, more pathogen agnostic, so targeted shared immune pathways, and more tightly integrated with classical anti-infective drugs. To conclude, immunotherapy for infectious diseases shows yet another side of the immune system as a therapeutic target. In cancer, we often push immunity harder. In autoimmunity, we teach it to calm down. In infections, we sometimes need both, helping the host clear pathogens more effectively while preventing the immune response itself from causing collateral damage. From monoclonal antibodies against RSV or Ebola to virus-specific T cells in transplant patients to cytokine modulators in severe COVID-19, these approaches are already reshaping how we treat some of the most challenging infections. The coming years will likely bring broader neutralizing antibodies, in vivo immune programming, and smarter combinations that make immune modulation a standard partner to antibiotics and antivirals. In our next chapter, we will stay with the theme of immune intervention, but shift to yet another high-stakes arena, immunotherapy in transplantation. How we prevent graft rejection, manage graft versus host disease, and work towards true immune tolerance. Before closing, I have a small request. If you like my content and want to hear more, please like and subscribe. It's a small step for you, but it helps me a lot. So thank you for listening and see you next time.